Not every ICU admission is because a patient is critically ill. Sometimes they are admitted just for routine monitoring, and occasionally that's exactly what saves a life. This was a 27-year-old female who underwent an uncomplicated cesarean section. She arrived in the ICU as a part of our standard post-op protocol. Only 15 minutes later, she suddenly developed a narrow complex tachycardia with a heart rate of almost 180 beats per minute. The rhythm was consistent with supraventricular tachycardia associated with intermittent varices and fortunately converted back to sinus rhythm after carotid sinus massage. Initially, the ECG showed ST segment depression in leads V3 to V6, but these changes resolved after conversion, making the diagnosis far from straightforward. Within minutes, her clinical condition worsened. She became severely short of breath. Her respiratory rate increased to more than 40 breaths per minute. Oxygen saturation dropped despite supplemental oxygen. And on auscultation, she had bilateral fine crackles extending to the lung apices. Then came the biggest concern. Her blood pressure fell to 60/30 within minutes. Peripheral pulses become barely palpable. She had rapidly progressed into shock. Immediate resuscitation was started. She was placed on norepinephrine, invasive arterial line, and central venous monitoring was established. And serial EVGs demonstrated worsening hypoxemia with severe metabolic acidosis due to tissue hypoperfusion. Chest X-ray confirmed pulmonary edema, and she was started on non-invasive ventilation with careful sedation using dexmet. The next question was, why is a young postpartum patient suddenly in shock with pulmonary edema? Pulmonary embolism was considered because of the acute presentation. However, bedside echocardiography initially showed preserved left ventricular function without right ventricular dilation, and Doppler venous ultrasound showed no evidence of DVT. But the story continued to evolve. A repeat echocardiogram performed just a few hours later showed new global hypokinesia with an ejection fraction of around 35 to 40%. Cardiac biomarkers continued rising dramatically with TROP-I and NT-proBNP increasing over the next 24 hours. A subsequent echocardiogram showed a further reduction in EF to approximately 20 to 25%, despite a normal-sized LV ventricle and preserved right ventricular function. At this stage, the patient was managed as acute cardiogenic shock. Dobutamine was initiated and later escalated for inotropic support, while diuretics were administered for pulmonary edema. Electrolytes were aggressively corrected, particularly potassium, because of QTU changes on ECG. Although she developed a fever on the first day, extensive infectious workup including COVID-19, influenza, dengue, malaria, and autoimmune screening remained negative. Her inflammatory markers and leukocyte count gradually improved, making overwhelming infection less likely. The encouraging part of the story came over the following days. Her oxygenation steadily improved, her PF ratio almost doubled with NIV therapy, lactate levels fall significantly, TROP-I began to decline, vasopressor requirements resolved, and inotropic support was successfully weaned. After 3 days, she was completely off non-invasive ventilation. By the end of the week, she was off vasopressors and inotropes, fully alert, maintaining good urine output, breathing comfortably on room air, and hemodynamically stable. She was successfully stepped down from the ICU to the cardiology ward for further evaluation and recovery. This case is a reminder that postpartum collapse has a broad differential diagnosis. Pulmonary embolism, acute coronary syndromes, stress-induced cardiomyopathy, myocarditis, peripartum cardiomyopathy, amniotic fluid embolism, and sepsis can all present with overlapping features. The diagnosis may not be obvious during the first hour, but repeated clinical examinations, serial echocardiography, trending biomarkers, and timely escalation of supportive care can completely change the patient's outcome. Sometimes the most important investigation isn't the first one. It's the one you repeat when the patient's physiology changes.